introduction, and we're pleased to have you. And to open the session, we'll hear from Dr. Diane Rausch from the National Institutes of Mental Health, Division of AIDS Research, and she'll be opening the session. Diane?
Thank you, Cindy. So, welcome to this satellite session, No Getting to Zero Without Scale Up of Stigma Reduction. I'm really honored to be part of this important satellite on stigma because stigma and discrimination that results from stigma have adversely impacted every aspect of the AIDS epidemic since the beginning, and they continue to challenge any efforts to eliminate this disease. So, as we're all aware, the Getting to Zero campaign was defined on World AIDS Day and sets 3 goals: 0 new infections, 0 discrimination, and 0 AIDS-related deaths. So we're at a pivotal moment in this HIV epidemic where we really have the tools to impact the epidemic, to stop the spread of HIV, and dramatically improve the health and lives of people living with HIV. So drawing on the title from the satellite session, we asked the question, what will it take to reach the goal of getting to zero? Over the past 3 decades, there have been numerous attempts to reduce HIV-related stigma, but 2 approaches in particular have been championed by many. That is the scale up of universal HIV testing and access to treatment. The rationale has been if we can normalize testing and ensure that HIV is a chronic disease and not a death sentence, this will reduce stigma. And universal HIV testing and access to treatment are 2 of the actions that could really help us get to zero. Unfortunately, what we've found out is stigma and discrimination actually have a negative impact on universal testing and access to treatment. So there's no getting around stigma. Instead, it appears that it's going to be necessary to directly and sufficiently impact stigma and discrimination in order to scale up strategies to meet this goal of getting to zero. So there's a very strong research component here that certainly our institute has been focused on, and that is that research can contribute in a lot of ways to the efforts to decreasing stigma and discrimination. Research can and should inform interventions to help people living with HIV cope with and combat stigma, and interventions to address stigma in healthcare settings as well as communities. But research design can also find ways to track and measure the stigma and the negative impact of it on universal testing and access to care. But research can't do it alone. It will require all of us working together, people living with HIV, key populations, researchers, program implementers, advocates, policymakers, and donors will be necessary to find strategies to really realize this goal. We have an outstanding panel of experts to present today who will highlight some of the key issues around HIV-related stigma and discrimination as key barriers to the use of HIV care, support, and treatment programs, which all fuel the spread of HIV. Before I introduce the co-chairs, I'd like to thank the co-sponsors of this satellite, the International AIDS Society, RTI International, UNAIDS, USAID-funded Health Policy Project, and the Stigma Action Network. And now it's my pleasure to introduce the co-chairs of the satellite, Laurel Sprague, who works with grassroots and community-based organizations to support participatory and community-based projects and conduct program evaluation. She's provided technical assistance on the People Living with HIV Stigma Index, which will be critical in our future efforts. She's currently a PhD candidate at Wayne State University and serves as the regional coordinator for the global network of people living with HIV in North America. And the second co-chair is Dr. Cheryl Smith, the founder of the Mount Morris Medical, a primary care practice in Harlem, New York. She currently serves on the International AIDS Society Governing Council as a North American representative, and she serves as chair of the Governance and Membership Subcommittee. So I'll turn this over to them, who will introduce our speakers, and I look forward to a very exciting satellite.
Hi, everyone. It is a great pleasure to be here with all of you as someone who has worked in stigma research for the last few years, and as a woman and researcher who is myself a person living with HIV. It gives me a wonderful feeling to sit here with all of you and with the panel here to focus on how we make this better, how we reduce the suffering, the violence, direct and structural, and the other violations of human dignity faced by people living with HIV in every country of the world, sometimes on a daily basis, and often faced with great resilience, courage, and resourcefulness. I think that the presentations that you are about to hear will invigorate and excite you. So I would like to spend a few minutes giving a brief overview of HIV-related stigma and discrimination. These definitions are probably familiar to most of you, but we felt it would be helpful to provide a basic foundation from which the presentations that you're about to hear will build. Many of you will recognize our debt to Goffman and to Parker and Aggleton for the conceptualizations used here. Stigma is a complex social process in which people are devalued because of some trait that they have or we have. This can be based on race, sex, illness, language, religion, is often dependent on the context in which we live, which particular traits are considered valuable and not valuable. This means that some members of society are considered to be less valuable human beings, to matter less, and other members of society are considered to be more valuable human beings, to matter more, to be better, cleaner, more reliable, more deserving, more fit to hold positions of power, simply because they do not have this trait. A range of violations of human dignity follow, such as inequity, devaluation, social exclusion, and disqualification from social acceptance. This process makes it very difficult for the people who are stigmatized, and in this case we're talking about people stigmatized because of HIV, to be able to mobilize on our own behalf and to be heard by those in positions of power. Discrimination is unjust and unfair action toward an individual or group on the basis of their real or perceived status or attributes, these devalued attributes that I mentioned earlier. These can be medical conditions like HIV and AIDS, it can be related to socioeconomic status, gender, race, sexual orientation, sexuality, and many other characteristics. When we talk about stigma, we use some specific terminology that I want to make sure that people are aware of. These are different manifestations or different categories of stigma. Enacted stigma or discrimination is stigma that is enacted by someone against someone else. So in terms of HIV, stigma enacted against someone because they have HIV or because they're perceived to have HIV. This can include things such as gender-based violence because of someone's HIV status, exclusion from family or social affairs. It can also include legal discrimination, discrimination written into the law. Anticipated stigma is the fear of stigma. This can stop people who don't know their HIV status from testing. It also stops people around the world who are HIV positive from accessing care when they need it. Internalized stigma, this is self-stigma, stigma that people living with HIV often feel about ourselves. The messages that everyone else hears about people living with HIV, we hear too, and often internalize those messages. This leads to suicidal thoughts, feelings of guilt, feelings of shame, and self-hatred. Secondary stigma is stigma that is enacted or that is felt against those who are associated with people living with HIV. Healthcare workers who work in the HIV field are often targets of this secondary stigma, as can be family members, partners, and friends. And finally, intersecting stigma, which is also called layered stigma or compound stigma, which occurs when multiple different categories of stigma come together in one human being. As we know that we are not only people with HIV, we are also people who have a race, who have a gender, who have a sexuality and a sexual orientation. And many of those identities are also marginalized for people with HIV, and so we may have intersecting areas where all of these different stigmas come together to create an overall complicated system of value and devaluing. So that's the end of my short lesson, and I will now turn over the podium to Cheryl Smith.
Again, thanks for coming to our session today. The International AIDS Society is happy to be part of such a wonderful and engaging panel discussion. I'd like to just get to the exciting speakers because I know that we would like to spend as much time in conversation with them at the end as well. So our first speaker to kick off this conversation is Dr. Stephen Barrow. He's a physician epidemiologist faculty in the Department of Epidemiology and Associate Director of Key Populations for the Center for Public Health and Human Rights at Johns Hopkins School of Public Health. So welcome.
So welcome everybody. I just want to say that it's really an honor to be on this panel. It's such an esteemed panel, so thank you very much for including me. So the title of my talk today is Stigma and Discrimination Reduction as an Essential Part of Combination Prevention. And what I hope to do today is present a framework that we use to look at the links between stigma, discrimination, and HIV risk in terms of how we've conceptualized it. I'll talk about what I consider to be some of the prerequisites for HIV prevention research. And then I'll use a case study approach with a focus on key populations to really explore the relationship between stigma and being able to effectively do prevention research and programming. I'll talk about some broader barriers to prevention and then some very brief thoughts on moving forward, given that the other speakers will be focusing on that. So some of you are familiar with the reproductive rate. So this is the rate that a system that we use to look at whether an epidemic is increasing or decreasing. Right? And so it's the average number of cases that are going to come from one existing case. So for example, if the reproductive rate is more than 1, right, that means that more than 1 case is going to come from an existing case and an epidemic is increasing. And if it's less than 1, it means that the epidemic is shrinking because less than 1 case on average will come from an existing case. And it has 3 main determinants. The beta, which is your acquisition and transmission risks, or your probability of transmission. Your C, which is your average number of contacts, and D, which is the duration of infectiousness. So what are some of the links? Well, for the beta, we're looking at acquisition and transmission risk. So any barriers to accessing commodities like condoms and condom-compatible lubricants, clean needles for people who use drugs, information on risk reduction counseling, services, including peer education, all of those are going to increase your acquisition and transmission risks. In terms of exposure risks, we're talking about coerced sex, sexual violence, or rape as a tool of war in terms of increasing numbers of contacts. And finally, the duration of contagiousness. Now that we're firmly in the era of the understanding that viral load and contagiousness are firmly linked, any delays to treatment or gaps in treatment, including forced detention, stigma in healthcare settings, which is going to limit treatment uptake, are all going to increase duration of contagiousness. And I'm going to use key populations, as we'll speak about, as an intersection of extremely high HIV risk, a significant amount of social stigma, and the fact that they're criminalized in many countries around the world. And there's the 3 universal key affected populations, including sex workers, gay men and other men who have sex with men, and people who use drugs. And I'll just briefly say that I think the epidemiology now is clear, and it likely always has been, that sex workers and men who have sex with men carry a disproportionate burden of HIV. This is from a systematic review that we completed earlier this year. But basically, looking at 100,000 sex workers around the world, we found that the pooled prevalence was about 12%, and that the odds ratio for a female sex worker to be living with HIV as compared to other women was about 14. And importantly, this held up in Africa, where it was about 12 times increased risk, and more so in concentrated epidemics like we see in Asia, where it's about 30 times, i.e. that a female sex worker has 30 times increased chance of living with HIV compared to other women. And the same thing is true for MSM, that around the world, wherever gay men and other men who have sex with men have been studied, they've been found to carry disproportionate burden of HIV. And while the background epidemics may vary, whether they be the highest risk population or whether we be talking about a context where the rates are mostly contextualized or driven by injecting drug use, MSM carry high risks. And so I don't want to focus on that as many of you should come to the Lancet session on Tuesday, which will be the focus. In terms of HIV prevention research, and again, I just want to give this as an overview, but we really traditionally talk about 3 types of interventions, or 3 buckets of interventions, including behavioral interventions. These interventions at the end are really focused on increasing condom and lubricant use during sex. So this is peer education, risk reduction counseling, adherence counseling. Biomedical interventions are different. They're not aimed at changing behaviors, but they're aimed at changing acquisition transmission risks during behaviors. So oral or topical antiviral chemoprophylaxis like PrEP or rectal or vaginal microbicides, treatment as prevention. And then finally, structural interventions, and we heard an introduction to that earlier. And there's been a limited amount of data around structural interventions in terms of efficacy and effectiveness data, but it's emerging, and we know that there's a variety of approaches, including decriminalization and government-sponsored anti-stigma policies, gender engagement programs, building community or working with communities for system strengthening, and finally engaging with the health sector. But what are some of the prerequisites for HIV prevention research? And I think of there being at least 3 things. Well, for MSM and sex workers, you have to be able to identify, right? So there is no magic marker that tells you that somebody's an MSM or somebody's a sex worker. So people have to be willing to self-disclose. They have to feel safe to do that. You have to be able to appropriately stratify them according to risk, right? MSM come in low, medium, and high risk as it does anybody else. And so people have to be asked about their risks in a competent manner, implying a competent healthcare system. And finally, you must be able to do follow-up. Whether you're talking about programmatic interventions or research, you have to be able to retain people to assess efficacy or effectiveness. And so you need a safe environment, you need community partnerships, and you need client trust in the healthcare facility. So I'm going to look at some case studies, sex workers in Russia and Swaziland, and men who have sex with men in Gambia and Malawi, to look at some of these links. So in Russia, again, we know from studies that we've done, as well as others, that female sex workers carry disproportionate HIV as compared to other women. And what the focus there has been is on increasing condom use during sex and working with sex workers to increase condom use. And so I just want to read some quotes from a study that was done by Michelle Decker and Andrea Wirtz from our team. So sometimes I pull on a condom and he pulls it off straight away. I pull it on once again and he can give me a punch for that. Or I say to a client that I don't practice anal sex and he replies that he doesn't need it. When I come to him, he just starts beating me up to make me do whatever he wants. So you see in these settings that the exclusive focus on getting sex workers to increase condoms really wouldn't have much traction unless you're addressing the settings in which that they're selling sex. And surely when we looked at HIV risk in this same work, what we saw was that reporting a history of client physical violence made sex workers 3 times more likely to have HIV or be living with HIV than other women who didn't report client physical violence. So again, the need to address these contexts in which sex workers are working in order to ensure that they're protected. Moving on to Swaziland. So this is from a study that we did last year in partnership with the Ministry of Health. And there, sex workers, just to show that across age groups, sex workers carry disproportionate HIV compared to other women in the background. In our study, it was over 70% compared to about 30% in the background. And that held true at all age ranges. But what are some of the other issues that are driving HIV risk amongst these women? So of about 313 of them, about 44% reported being afraid to seek health care. Many of them reported legal discrimination, blackmail, torture, and having been beaten up. And when we looked at who was beating them up, what we saw was that it was most commonly uniformed officers, also family members. And so again, in these settings, how can you imagine that you could effectively either do research on prevention or do prevention programming? And when we looked at disclosure, we saw that about 30% had disclosed their sex work status or being a sex worker to a family member, and only about 25% to a healthcare worker. But when we looked at associations about being afraid to seek healthcare, we found that women who had disclosed their sex work status to a healthcare worker were 3.5 times more likely to be afraid to seek healthcare. And similarly, those who were being treated for HIV were 2 times more likely to be afraid to seek healthcare. So it's starting to give this impression that something's happening in the healthcare setting that's making them afraid. In the Gambia, from a study we did last year, showed about 10% prevalence among MSM in the Gambia and about 1.4% in the general population. And earlier this year, 20 men were accused of attempting to commit unnatural offenses. So this is the actual statement of offense, and I'll just read it very briefly. It says, the attempt to commit unnatural offenses contrary to section 145 of the Criminal Code. You jointly attempted to commit an unnatural act by conducting yourselves in an unindecent manner in a public place. Thereby you committed an offense. And I'll skip count 2. This was the media that ensued immediately after that. This is May of 2012. Death and hellfire for homos. This is a famous imam in the Gambia. Cocoa Ocean Boss is a homo, and so on. So you can imagine, what is your willingness to disclose your status as being a gay man or an MSM in these settings? Again, associations with disclosure, not surprisingly, only 4% had disclosed their status to a family member, and only about 15% had disclosed their status to a healthcare worker. And when we looked at any disclosure, we found that those people, again, who had disclosed their status were 2.5 times more likely to be afraid to seek healthcare, and also were nearly 10 times more likely to be denied healthcare. Malawi. So our last case study. We've seen HIV prevalence of 20% among MSM and under 10% in the general population. And many of you may remember these incidents when Stephen and Anne Tuange tried to get married or had a traditional marriage. And it started an incredible amount of media, including police hunting for prominent gays, closing in on gays. And again, you can imagine what is your willingness to disclose your status in these sort of settings. Our partner SetUp and others doing workshops trying to train media and having been interrupted in those workshops with people protesting as a result. And even as late as May 2011, the president at the time reporting that gays are worse than dogs. And again, so you just have to sort of imagine yourself living in these environments and your willingness to disclose. So in terms of reading this table, I'll just start with our top. What we're looking at here is people who had been diagnosed with an STI were 2.5 times more likely to be afraid to seek health care than those who hadn't, and were 7 times more likely to be denied health care services. But I just want you to point your attention to this one data point. Those who reported self-reported treatment for HIV were 4 times more likely to report being afraid to seek health care, but were almost exclusively or 50 times more likely to report having been denied health care. And again, they were 5.5 times more likely to have been blackmailed as a result of that disclosure. So you can see these sort of intersections that are taking place. And in any interaction with the healthcare system, the same held true. People were afraid, and they had a right to be afraid because they'd been denied and blackmailed as a result. But I just want to end the case studies on a positive note, which is that things are changing in Malawi. We have a new president, the first female president of Malawi, Joyce Banda, who's promised to overturn the sodomy laws there. So we hope that this is sort of a positive change and that we'll see the effects of that. The messages here are that there's going to be limited capacity for prevention research if populations are afraid, they live hidden, and you have limited access to safe and effective clinical care. It's just impossible to operationalize either studies or programs with effective coverage in those settings. And then I just want to briefly talk about some broader issues that transcend the country level. So even in concentrated epidemics where MSM and sex workers are the predominant risk groups, we see about 5% of total non-treatment expenditures supporting their needs. And in generalized epidemics where we have emerging evidence of their risk, we see less than 0.1% of non-treatment expenditures supporting their needs. And many countries have really invested $0 in these things, of domestic expenditures. So again, the idea that that responses are being diverted to respond to the needs of MSM and sex workers just isn't founded in data. I'll also mention that a barrier to doing work with sex workers is the anti-prostitution loyalty oath, or many of us know as the anti-prostitution pledge. So this is that all international organizations that receive PEPFAR money have to promise to not do work with prostitution because it supports sex trafficking. It was signed in with the first PEPFAR in 2003 and with the reauthorization. And realistically, and we have data to show this, it just has decreased the amount of studies that have been done with sex workers in the last 8 years. So we had a better understanding of sex workers in the 90s than we do now. And there's a lot more data coming out about this now, but just to briefly say that, criminalization affects the ability to spend money. What we've seen, and we have a more detailed analysis of this, is that 7 of the top 10 countries receiving the greatest support from the Global Fund criminalize same-sex practices. And more than half of the 88 countries supported through PEPFAR also criminalize same-sex practices. So again, looking at those case study messages, you can imagine the difficulties in operationalizing both research and programs in those contexts. So some conclusions. I hope I've made the case that stigma, rights violations, and HIV are intricately linked, and other speakers will also talk about this. And to test combination strategies, we have to address stigma. But then also, when we get outside of the trial settings to implement and operationalize these programs, we also have to address stigma. So I was asked to give some thoughts about how you would address stigma. And I'll just say briefly, I'm not a government or funder, and I'm not an implementer, but I'll say that I would imagine that anti-discrimination clauses in all policy programs and RFPs and RFAs that go out seems reasonable, because we know that many of the people who get US government support are also sometimes the perpetrators of some of this stigma. Implementers large and small, I would just say that engagement has really seemed to be effective, and I think we've already spoken about that. And finding champions within target communities and outside of them and empowering them. But I'll say for academia, all epidemiological research should include an assessment of enacted and perceived stigma. That linking HIV with unprotected intercourse or higher numbers of partners or STI, I don't think as a junior researcher that it contributes to our knowledge of HIV risk anymore. I think we have to sort of think past it. I think we have to use the opportunity of these assessments, whether it be size estimations or cohorts or cross-sectional studies, prevention studies, any of those to collect actionable data about stigma and discrimination. Realistically, stigma manifests different in every country where we've explored it. Sometimes it manifests in the family, sometimes in the healthcare setting, so there is no universal truth, and we really need to understand it better. So on that, with 7 seconds to go, I will close, and thank you very much for your attention.
Does this work? Yes. Thank you very much. I'd now like to introduce Dr. James Blanchard. Dr. Blanchard is currently a professor in the departments of Community Health Sciences and Medical Microbiology, and India's director of the Center for Global Public Health at the University of Manitoba.
Thank you very much. I'd also like to say what an honor it is to me, for me to be able to speak here, and thank the organizers for inviting me to do so. I'm going to be talking about closing the gap between research and programs for scaling up strategies to reduce stigma and discrimination. I'm going to talk first about the concept of the gap between research and programs, and then walk through an example of a scaling up process to address stigma and discrimination related to female sex work in India, and conclude with some observations about how we might be able to move forward, both from a research side and also from a program side, to try to integrate research with programs in this field. So first, let me talk about the gap, and I think there's at least two gaps. The first gap between research programs is a perspective gap. The paradigms for research and programs are not always well aligned, and I illustrate at least three areas here. First, the research paradigm relies heavily on theory to build knowledge and develop interventions, very much an approach of taking the theory and developing an intervention, whereas programs often rely on experience and community perspectives to develop interventions, particularly those that are addressing stigma and discrimination. A research paradigm relies heavily on internal validity for building knowledge and testing interventions, whereas programs necessarily often focus on local context, community responses to assess whether their interventions are effective or acceptable. And the research paradigm from a knowledge translation perspective really focuses around the idea of getting research into practice. We have this research, we know that this is an effective or an efficacious intervention. Now we need to make sure it gets into practice. Whereas programs are more interested in understanding what's working within their programs and getting research out of practice. And so I think that these are the perspective, this is the perspective gap. But there's also an implementation gap. In terms of research and programs, and they live in different worlds with respect to implementation. So from a research paradigm, there's really an emphasis on adherence and fidelity to proven interventions. From a research modality, you have to focus on fidelity with what your intervention is in order to look at what its effect is in a population. Whereas programs often have to emphasize adaptation to local situations and have flexibility in their design. The research paradigm usually focuses on clear, measurable indicators to assess the progress and effectiveness, whereas programs often give priority to experiential evidence and give informant feedback to measure success. And the research paradigm usually operates in a different environment. They usually don't have robust program contexts. They often are constrained or squeezed into research contexts, which don't necessarily give them the breadth of experience. And from a program side, the context is often constrained with respect to being able to access resources and use expertise to engage in research. So you have these inbuilt gaps between research and programs. There's a number of organizations and institutions that are trying to close the gap. I'm just referring you here to a paper that we recently wrote on this. But what we've talked about is trying to close this gap between program and science through the systematic application of theoretical and empirical scientific knowledge to improve the design, implementation, and evaluation of public health programs. And the idea here is really to put the program at the center of research efforts. I'd like to now share an example where we've learned a lot from the research perspective about how to think about research in the context of scaling up stigma and discrimination. And this is an example from work that we've done with female sex workers and female sex work organizations in India. I think female sex work in India, as in many contexts, is really a very strong example of what Laurel described as intersecting stigma. Sex workers in India live in poverty quite often and have very low social standing. Most or many female sex workers are particularly of low caste. They have economic dependency. They don't have power over resources. They lack access to health services. But there's also moral and legal aspects to the stigma. So, and this really promotes and sanctions harassment, exploitation, and violence by police, power brokers, and members of their own families and communities. And also, the moral and legal aspects of sex work leads to an internalization of the stigma with feelings of unworthiness and lack of entitlement to human rights, and therefore lack of propensity to advocate for their own rights. And I think HIV layers on the stigma because in many circumstances, sex workers are seen as the cause of the epidemic, and they're seen as a threat to the community, and this really accentuates their social exclusion and the resulting stigma and discrimination. In response to this, and through a lot of interaction with sex worker communities, our program in India really sought to come up with an organized response to stigma and discrimination through structural interventions. And we really looked at 3 different areas that were felt needs within the community and expressed needs within the community. First was to help work on changing public attitudes and the stigma that results from that. And so there was a lot of emphasis on media advocacy. At that time, most of the media stories really focused on sex workers as the cause of the epidemic, as dangers to society, et cetera. So we actually had a very large-scale program of working with local media cells to try to improve the quality of reporting, to engage more in telling more positive stories about the lives of sex workers and what they were facing and what they were trying to do as part of a solution to the HIV epidemic, and also supporting local organizations that would advocate from within sex worker communities to try to change public attitudes. There was a felt need to address the social and economic issues, particularly the exclusion from rights and access to social entitlements, and also the strengthening of community-based organizations that could work coherently and jointly to promote access to social and economic entitlements. And then, of course, addressing the direct violence and exploitation. I think Steph gave a very compelling story of the kind of violence that sex workers often face in different areas. And so there was a very large-scale program to try to address violence and exploitation. One of the key areas or one of the key sources of violence and exploitation is from the police. And so there was a very large-scale program, and I'll show some of that. There's a very large-scale program focusing on police sensitization and a crisis response. This is just an example of the scale of police officer training that was done in each district. So a very large-scale program. The details aren't important, but the idea was to go to every single district and train all of the police officers on issues of how they could be better part of of a positive response for HIV prevention. And we tracked how this was changing attitudes before and after training. And we also tracked the report of violence, either from police or those in uniformed services or overall, and we found significant drops in the report of violence over the years by sex workers. We also focused a lot on community mobilization, programs to try to enhance the dignity and self-esteem of sex workers, to address some of the internalization of stigma, support sex workers to develop a strong and shared voice around issues, advocate for their own rights, and also build the capacity of these organizations, both not only to effectively advocate for their rights and to address stigma and discrimination, but actually to be part of the response and to lead programs. So now a very large percentage of all of the HIV prevention programs in the state of Karnataka are run by sex worker organizations themselves. So there's a substantial amount of work going into building the capacity of organizations once built. So it's moving beyond just addressing issues of rights to the issues of who's actually providing the services. This gives an example of some of the progress in the development of sex worker collectives. We look at the number of sex workers, the number of women. The total membership in the collectives in Karnataka is now well over 40,000. Women are involved in more than 20 different collectives which are organized at district level. Many of these collectives have very large corpus funds as well, so that they can develop their own programs to address social needs and other needs of sex workers within their organizations. And we've tried to systematically promote sex workers from being peer educators to having more responsible and more senior roles, from project director to supervisors and other supervisory roles. So we try to track the number of peers who have been promoted into senior roles within the program, as opposed to remaining in, as peer educators. So there's a lot of different things that were done in the program, and they were done in a very responsive or reflexive way, listening to the community, understanding what were some of the constraints for the community being very vocal about what the issues were. And we had a very responsive funder in permitting us to try different things with the community related to empowerment and stigma and discrimination. But what we realized was that replicating this, or thinking about this and researching this, we hadn't thought through how these fit within a broader conceptual framework. So we can describe them as an experiential thing, but the idea is, how do you translate what was done and what was important to be done? How do we translate that across contexts, other than just writing up and describing what we did? And I think that also, we didn't start with explicit empowerment objectives at the individual level. It was sort of this organic process of responding to needs as they went along, but we hadn't thought through what we were going to measure, why we were going to measure it, what was the framework by which we would develop these measurement tools. And so we've retrospectively gone back to try to develop a framework that we think would be useful for studying the process of developing structural interventions and then measuring the process going forward. And I'll just give a quick illustration of that. So our program science framework for looking at stigma and discrimination, which is evolving, this is very new work for us, but we're trying to evolve concepts that we think will help us measure and study and design interventions and evaluations of interventions. So if we think about, from the top left-hand corner of the slide, if we think about the different kinds of areas that lead to disempowering circumstances, or that could change the empowerment circumstances, we have the socio-demographic characteristics of individuals who are in sex work. We have community mobilization processes, and we have program and structural interventions that are meant to change the empowerment dimensions. But we also wanted to recognize that when we think about empowerment and power, there's different types of power. There's power within, which really relates to the internalization of stigma and power, and also the self-efficacy for dealing with issues of stigma and discrimination. So we recognize that there's a domain of empowerment, or a dimension of empowerment that really relates to addressing power within. There's the whole area of power with others, the collective power, the idea of working with others with a common voice and gathering and borrowing strength from each other. And then there's the power over resources, the very practical issues of if you don't have resources, economic resources, or access to resources such as health services, then you remain unable to address some of the key issues. And that by addressing all three of these domains, it improves sex workers' power to address the various power imbalances they have at individual and individual relationships and with power structures, to address the social exclusion that they feel, and together address their vulnerability to HIV and AIDS. So the idea is to really think through the different components of a program and how they map to different types of empowerment or lack of power, and how then these relate to vulnerability for HIV. So when we look at the empowerment domains, the power within is really measuring self-esteem and confidence to participate in meetings with other sex workers or health and social workers. So trying to come up with good measures of power within. Power with is really looking at the confidence and the ability to work with others and support each other and the benefits of collectivization. And then power over resources is represented by things like social entitlements, having a bank account, having a voter ID or an ID card and ration cards. And then what we've tried to do is we've tried to measure these empowerments. And I just wanted to illustrate that these types of power can be measured separately, and you can look at it across context. So this just shows 5 different districts, and the power within, the power with others, and the power with, and how these differ between different contexts. Our key findings: younger women scored lower in all empowerment domains, considerable variation between districts. Duration of time exposed to the program and the number of program contacts was really positively associated with power within and power with, not necessarily power over resources. Power within was associated with greater self-efficacy for condom use, greater autonomy was associated with power with, etc. So we're trying to look at the relationships between these different power domains. I think I'm going to move beyond this one and just share some final thoughts. I think we've learned that putting the community at the center of the program science platforms is really important. And it's very important to get communities participating in all aspects of the research, design, and contact. So I know my time is up, and I wanted to thank you for your attention.
It's not up. Thank you. I'd like to bring Laura Knifelade up to the stage. She's a senior technical advisor to the Health Policy Project and the Global Health Group at RTI International. Welcome.
Thank you, and thank you so much for being here this afternoon. I know there's a lot of choices out there, so we appreciate your support by being here. So I'm going to change into a little different direction from the previous 2 talks and look at what we've learned from programs. As Dr. Blanchard said, there's this sort of these gaps and these paradigms. So what is it we've learned more from the program side? He shared a bit of that, but I'm going to look at this more generally. So I'm going to look a little bit about what we've learned around fundamentals for stigma reduction programming globally. So looking at this from a very broad perspective. What is it we've learned from the field of programming, and how can that be brought forward as we think more about the issues of research? And then I'm going to just try to make that a bit more concrete for you by looking at what's been going on with some examples in the healthcare setting, how they've brought these principles together. And then taking it back up to a very broad level to think about, the title of this is how do we scale up stigma reduction? So what is that going to take globally for us to do? So looking at what are the foundations we already have in place, And what are some of the gaps we need to fill? I think we've heard a little bit about that already. So with that, I'm going to jump right into some of the fundamentals. What we've learned from our global programs on reducing stigma and discrimination is that, yes, things vary by context, and there's a lot of drivers or causes of stigma and discrimination, but there's also some things that seem to be very fundamentally common across contexts. So stigma is a very fundamentally human attribute, and there's some things that we find that programs can shift actually quite quickly. It's quite surprising. So these are kind of three fundamental things that we find that any program, no matter which type of stigma they're working on, which groups they're working on, these need to be there. The first is raising awareness. So helping people understand what stigma and discrimination is, what it looks like, and how we actually engage in it and what it does. What we find in a lot of the research and work in communities is that people's intentions aren't to harm. They aren't bad. People aren't bad at heart, but we don't realize that when we're doing certain things, that is stigmatizing and it has an incredibly devastating impact on others. And we find that programs that just help people understand what is stigma, what does it look like, how am I doing that in my daily life, actually can have a large effect in those communities. So it's really closing the intention-action gap, as we call. The second is, yes, we still have a lot of myths and misconceptions around how HIV is transmitted. And there is still a lot of fear around casual transmission of HIV that drives stigmatizing behavior. And it goes to the core of things like people's livelihoods. So fear, for example, that if someone's living with HIV and they cut themselves and they're cooking and I eat that food, somehow I'm going to get infected with HIV. Not possible, but that drives, we've seen in communities where people will lose their livelihoods for selling food because this fear still continues. So it's helping people really understand how HIV is and is not transmitted and addressing their concerns in their daily lives. So it's surprising that here we are this far along and this is still an issue that we need to address. And the last, and I think this has been brought up by both our previous speakers, is really the sort of the moral dimensions of stigma. We need to discuss and challenge the shame and blame. We need to find safe spaces, and this works best when you're doing it interactively in a non-threatening space, to talk about the values and beliefs that underlie stigma and discrimination. Where are they coming from? What are they doing? Why are we doing them? What does this drive? So these are kind of three fundamental basics for stigma reduction programming. So keeping those in mind, I'm going to talk now about a few other sort of fundamental principles that have already been addressed by our previous speakers, some of them. I think Dr. Blanchard talked a lot about this, and so I won't spend a lot of time on this, but really ensuring that affected groups are at the core of the response for scaling up stigma reduction and that they are leading that response, and ensuring that groups have what they need to be able to do that effectively. And we know from our programs that those that are most effective are those that are designed and led by people living with HIV or sex workers or men who have sex with men. So putting that at the core of any work that is looking at scaling up, and I think we talked also about research. The second is creating alliances and forming new partnerships for influence and expanded reach. Again, I think there was a discussion earlier about this, but what we find is that programs that really work to engage a range of opinion leaders, people who shape the norms and values and who shape the behavior, so the people who they model behavior, working with these groups, helping them understand what stigma and discrimination is and what it does in their communities, and creating alliances between those who are experiencing stigma and discrimination and those who are perpetrating. So really breaking down that distance. This is what effective stigma reduction programs do. And they need to happen at multiple levels if we're really going to scale up this response. The other is employing a range and combination of approaches. We find all of us learn and change in different ways and in response to different things. And there's been a few programs that have seen that there's actually kind of a dose response going on. So if you have multiple types of programs going on in a given community that are addressing stigma and discrimination, the more of these that someone is involved in or exposed to, the more likely they are to have a reduction in their own stigmatizing attitudes. So really looking at having a range of things that go on to really address different people and different ways that people learn and change. So now I want to try and bring that down a little bit more concretely for you by looking just briefly at 2 examples in the healthcare setting to show you how some of these things are brought together in actual programming. So this is going right down to a much detailed level. So the first I want to talk about a hospital reduction intervention package for stigma reduction that was done by the Horizons program, ISDS and ICRW several years ago. And this brings together a lot of the things that I've discussed. The first part of it is really building partnership with hospital gatekeepers. So getting entree into an institution or a facility and then having data that comes in play to really help the gatekeepers understand that this is actually an issue and what does it look like and what will happen or what are the benefits of actually doing something about this. So it's bringing that in. And then having participatory training for all staff in the health facility, right from the guard up to the senior doctor. And in this training, it included addressing the 3 things that I talked about, as well as some additional stuff around infection control in hospitals and risk of infection because of that. And then what was really important, I think, was also more of a structural intervention, which was really that once everyone was trained, the staff actually developed their own hospital policies around stigma and non-stigmatizing and discriminatory behavior and making that a part of their daily code of conduct. So this was just a way to show sort of how those principles come together. And then going back to India, looking at different ways that groups experiencing stigma, in this case sex workers, actually worked to address stigma and discrimination in healthcare settings. And I don't show it here, but backing up, a big part of both of these programs was really around building, strengthening the capacity of the sex workers themselves to design the programs and then carry them out. So in the one program in Mysore, they trained peer patient advocates and placed them in public hospitals. So these were sex workers who were trained to actually help their peers navigate the hospital setting, ensure that they were given appropriate care. But what was interesting about this was that it really created an opportunity for contact and understanding between the sex workers and the staff in the hospital. So it really worked to start breaking down that sort of us and them distance that we see with stigma, to understand that we're really all the same. And they saw improved access and utilization of health services among the group that was doing this. Another group in Bangalore, they designed a campaign, an advocacy campaign, and they went into the public hospitals where a lot of the sex workers seek care, and they gave roses to all of the doctors and nurses that had given them respectful care. And what was interesting about that was it opened up a space for dialogue, because now everyone was talking about, well, why are those doctors getting roses? What is this about? And so it really created a discussion. And what's interesting about that is that this is a teaching hospital, and it actually developed a medical student rotation now where the medical students are actually going to the sex worker collective to do part of their rotation. So this came out of that. So just to give you a flavor for the different ways in which you can actually sort of concretely do stigma reduction programming. So now I'm going to take it back up to a much different level. This satellite is about scaling up stigma reduction. And when we think about that on a national level or on a global level, what does that mean? How do we create readiness for scale to actually do the scale up? Big part of that is building joint action, and we're starting to work on that, and I'll mention an action network a little bit later, and establishing a stronger case for the importance of doing stigma reduction. I think our previous speakers have shown that this is a really critical issue if we're going to have effective programs. So how do we do that? We still have some gaps, and these are kind of 5 big buckets, and I'm only going to talk about 2 of them, but I think the good news is that we have a strong basis in all of these for actually moving to scale up. We do still have some gaps to fill. I'm just going to focus on 2 of them. So the first is the evidence base, and we talked about the research programmatic gap here. There's a lot that we know from the past 2 decades of work. I think we know a lot about the causes and manifestations and consequences of stigma and discrimination. I don't think there's any question that stigma impacts HIV and AIDS programs. We maybe don't have certain kinds of data around that. We know a lot more now about how to measure stigma, how to reduce it, as I was just speaking about programmatically, and then what works in different contexts. But we still have some gaps. And one is that we really know very little around how stigma and discrimination is being included in national strategies, or if it's being included in national strategies or national responses to HIV. And we have one speaker here who will talk about how that is happening in Thailand. But we actually know very little about that. We also know very little around, for example, global fund proposals. We know that often stigma is listed in those, but we don't actually know what happens then. Is it actually implemented, or is it just put in those proposals and then what goes on? So we need to know a lot more about what's actually going on in order to help us with the scale up. We need more program evaluations. A lot of the work that's being done, and you can see changes happening in communities, are not evaluated in a significant way, and so we need more work with that, including understanding when you reduce stigma, how does that impact actual outcomes that we're interested in. And then we need costing and cost effectiveness data. If we're going to scale up stigma reduction programs, we need to know how much they cost. And we do not have that data at the moment. And we need to know their cost effectiveness. So those are kind of some gaps that we have. So we have a really solid base. We still have a bit more to go, but these are the things we need to really push the field forward to scale up stigma reduction. Another place I want to look at is programming. We have a lot of good stigma reduction tools now that are around and have been used in multiple countries. We have a lot of good IEC materials. We have intervention models. We've heard about one today. We have measures. And we have a global voice now in the Stigma Action Network that brings together all of these practices and tools and communities that are working on this. But we still have some gaps. We don't have standardized program guidance. For example, there's no standardized PEPFAR guidance on stigma reduction programming. We don't have sort of that we need. And again, things are different in different places, but we could have some standardized guidance. We need validated and global indicators. We have good measures for specific settings, but we need to have that that are more global. And we need to institutionalize stigma reduction. By this I mean making it part of our routine practice. So, for example, all medical students being trained on stigma reduction, all nurses being trained. So making it a routine part of what we do, and ensuring that's incorporated into prevention and treatment programs as a core part of what we do to have effective prevention and treatment. So just to end by saying, stigma reduction intervention, you invest in stigma reduction intervention, and you have an effect in all of these areas. So it should be a very cost-effective intervention, because it's going to affect everything we do in our response to HIV. And I think, as our first speaker pointed out, if people can't disclose their status, whatever that is, if they can't be reached, if they're not safe to access services, we can have the best technology, but it's not going to help us. So I would say this is a very effective intervention. And just to end and say, you're all part of the solution.
So thank you for those very encouraging remarks. It's now my pleasure to welcome Dr. Patsy Serinirund, the director of Thailand's National AIDS Management Center, which is the Secretariat Office of the National AIDS Committee, chaired by the Prime Minister. The National AIDS Management Center coordinated the development of the National AIDS Strategy and is moving the national response at the policy level.
Good morning. No. Good afternoon. So you are awake. What I would like to share here is very pleased to have a chance to share what Thailand is going forward for the next 5 years. No, 4 years. This is the first year of our current national strategies. So the presentation today, I will start with some background of the HIV in Thailand and rationale, how we think about the inclusion of stigma and discrimination in our national strategy. And then I will share a little bit, but not a little bit, but more on the process of how it come about. And then going into the national AIDS strategies for Thailand from the year 2012 to 2016. And not only that, we realized that only the national strategy is not guaranteed that it will happen. So we talk about how we're going to operationalize it by developing the strategy information and monitoring and evaluation plan, and also the national biannual operational plan. To do our national strategy, we're also looking at the status of the situation of the HIV epidemic in Thailand. And we found out that using Asian epidemic model, within the next 5 years, we are going to have new infections around 4,000 people. And then among that, 62% of new infection will come up among the key affected populations. And not only that, 32% coming from spousal transmissions. It seems to be that if we can deal with these 94% of new infection, we can nearly getting to zero. And looking at the treatment and care, in Thailand we have the universal coverage. We provide the benefit package to all people living with HIV, and we can increase the coverage up to the current one is in 2011, we come up to 77%. But however, when we look at the CD4 level at the time of diagnosis and the initiation of the ART, we found out that people coming to us very late, 49% in 2011 coming at the time of diagnosis at the CD4 level less than 100. And then again, for treatment, the proportion of those starting ART under CD4 under 100 is come up to 57%. So we can see that people still don't reluctant to come to get the test, and even they have a test, they know the test results. Something around that make them not coming to be on the ART. So for that, we are very clear that our situation, prevention, there are still something to do, many things to do. And also the care, even we have a good coverage, but we still have how we can get the people come to treatment earlier. So for that is the brief situation in Thailand. And when we do that, we spend nearly 1 year to do the national strategies. So we use a lot of participatory process. No? The participation comes from government, from the civil societies, and also the private sectors, but not much for the private sector yet. And the other point, we use the evidence. In Thailand, civil societies always say that we are not the figures. Why your people, why the government only look at the epidemics? Or everything is epidemic, but it's not the life of the people. So I think relating to this S&D, the evidence very strong from the civil societies. They have done many years already about the report of the situation of AIDS rise in Thailand. It shows that it's still the stigma and discrimination still exists in Thailand. But however, we always say that we don't know the magnitudes, no, of how many or how much, no, but we realize that it exists in Thailand. And we also have the study on stigma index, no, together with other countries, so that those are evidence that we realize that we have to do with this. And in Thailand, the civil societies, they have a lot of participation, not only in Bangkok, but also around the country, getting the voice from the community. So I think this is the second time that they have civil societies. I will not say they, no, because civil society is we as well. The civil societies, they have the agenda for HIV and AIDS for every 5 years and to monitor. But however, those information has a very great push, no, for Thailand, for the government and also other sectors, no, talking about the human rights issues. I think stigma and discrimination is very close to the human rights aspect. We have the consultation among civil societies, we have the consultation among the government, and we have consultation together. And for this time, we also have the technical assistance, I think from RTI, that provide us. We have, particularly for the government side, we realize that for the human rights, we have to do the respect, protect, and fulfill. These three words, I think, is very meaningful, no, for us. And the other meaningful issue is the responsibility of the government. So from this, I think we have a good evidence, we have the participation, and we have the acceptance of the existing of this. So that's coming to our national strategies. So now I'm going to our national strategies. In Thailand, we're not getting to zero, but we want to have the AIDS zero. Our vision and goals here, we have 3 zeros like this. And also thanks to UNAIDS, that you have started with this getting to zero. So it's not so difficult for us to refer, to use as a reference, and then talking about what's the situation in Thailand, and then come to the goals, the common goals. We would like to reduce the new infection by 2/3. We want to have everybody in Thailand, not only Thai people, but also migrants, access to care. And then for this, we clearly stated that the goal for 2016 for zero stigma and discrimination, that all laws and policies which obstruct equal access will be revised. And the human rights and gender-specific needs are addressed in all HIV responses. And then coming to the reduction of the stigma and discrimination of people living with HIV and also key affected populations reduced by half. So these are our goals. We always use these 3 together, that the zero stigma and discrimination will increase access to prevention and care. And then for that, this also it's not like a 3 separate zero, but these 3 zero coming linked together like the previous presentation as well. For our strategies, we have 2 strategic directions. The first one is innovation and change. That will include mainly for the prevention. So we mainstream the rights-based and gender-sensitive issues, not for the comprehensive prevention service for population with risk behavior with highest number of HIV infection. And then the second is to expand the protective social and legal environment essential for HIV prevention and care. We have to talk about the laws and regulations or policies. And then also under the optimization and consolidation, we also have the separate stigma and discrimination programs. And then from that national strategies, I will not go into details, but to operationalize it, we also go to make it, translate it into the operational plan. And under the National AIDS Committee, we have the subnational subcommittee for the for promotion and protection of the AIDS rights. So this is the main areas that we are going to do next year. 2013 to 14. We have been, actually we have continued what we have done before. We review and change. We would like to change the law, regulations, but it's not really easy. We have done this a long time. So the policies is another thing that we can come up better. We talk about the harm reduction programs, we talk about the sex worker programs, and even the young people. In Thailand, young people, if they want to have a test or they have the STI, they have to have the consent form from their parents to get a test. To do that, they will not test anymore. And then the second area is we also have some enabling policies. We have the National AIDS Committee's policy that every workplace they have to do the AIDS program, particularly talking about the protection of the rights of the workers. And the third is we are going to establish human rights protection mechanism at provincial level. And the fourth is this is also important because the parliament people, many people, they will say that it's because of the public, it's because of the community that don't understand why we have to do the needle syringe program for the people who inject drugs, something like that one. So the campaign for understanding of the sexuality rights, AIDS rights and human rights is in one of our areas. And the fifth one, we consider that for the health services, that is very important services that can get people access to prevention or care, treatment and care services. So for this, actually in our programs, we don't talk about only the health services for the people that people has to access. Other public services, education and some other work for the employment, that's also that we think the government has to consider, has to be responsible that they are not going to to be the own barriers of those. And number 6 is very important. I think the previous presentation talking about this, that they have to be empowered. Last time when we developed the VTR for national strategies, and we got the sex workers talking what they are thinking about, and they say that they need not only condoms, but they need empower. So I think that's very important. For the M&E, monitoring and evaluation, we consider that we have to do the crisis response monitoring system in order to know and to understand the magnitude of the problem, and that will come back to improve the program. We have to establish new surveys to monitor the response. We have planned to do the people living with HIV survey and also the survey on the S&D. This is learning to start. So cheer us to get the A0. Thank you.
Thank you for a wonderful talk. If Susan Timberlake, Chief Human Rights and Law Division for UNAIDS Secretariat.
Hello, everybody. It's very good to be here. I want to start with something a bit provocative and then go on to my boring presentation. No, I just want to say that we've heard a lot of great things up here, a lot of great research, great programmatic responses, sort of laying out all the things we should do. But I want to say that unfortunately the world just doesn't buy it. And I'm going to talk about two different worlds. One world is our world, the HIV world. And the other world is the world beyond our world, you know, maybe some would call it the real world. But anyway, in the HIV world, there is still, believe it or not, 30 years into this epidemic, a tremendous disconnect between those who think that basically this is, all we need is more tests and more pills, and that will solve the problems. And in fact, I used to call it some of the great myths in the HIV world was that if you get enough people tested so enough people know their status, stigma will reduce automatically. If you get enough people on treatment, stigma will reduce automatically. I don't think we've seen the evidence that this is the case, but it's still, the belief is still out there. And now we're in an area, and we'll hear about it all this conference, where science is very exciting. And as we get to treatment as prevention, it's even more clear that all we need is more tests and more pills. And there's a tremendous push in our HIV world to go that way. So we are hearing a lot of great things about what we should do in the structural interventions, but I don't think even among ourselves are we convinced that this is the way we need to go. And then beyond our world, basically there are two things going on. One is there's huge cultural wars across the globe about what is the right social, cultural, religious approach to various human behaviors. And secondly, within that is the notion, a huge war about whether you have punitive approaches and whether you have protective approaches. And we're talking about protective approaches here, but the world out there is still very much organized around punitive approaches. So with those two thoughts, I guess, let me just talk briefly about the intersection of criminalization, discrimination, and stigma. I'm a lawyer, and so I'm not a researcher, and I'm not a programmer. So I'll have a very different perspective, perhaps, on these issues. But a lot of it reinforces what people have already said, and I'll try to go quickly over those sort of things. It's pretty obvious that the criminal law is driven by notions of moral judgment and punishment and trying to have control over human behavior. So we see that if you have certain attitudes and you make a certain treatment of people, you may want to criminalize their behavior to control their behavior. So there's a tremendous intersection among these three things. Now, on the one hand, we have countries reporting to UNAIDS, almost all of them, in fact, are reporting that they are doing something about stigma and discrimination. So when we look at this somewhat strange slide that even I don't understand, we see that basically we have almost, well, now we're at 89%. The reason the figures are dropping is not because less countries are reporting that they're doing something about stigma and discrimination. It's just a matter that whether countries have been consistent in their reporting in general versus on this issue. But the point here is just to say that if you look at this slide of what countries say they're doing, there's no problem here. They're all doing programs to reduce stigma and discrimination. And yet we know that stigma and discrimination is not, in fact, being reduced. Now, what is the disconnect here? Well, first of all, you probably can't read this, all this little colors, but basically what those little lines going down are what we call the 7 or 6 key programs that we say should be in every response. legal support, legal audit and reform, know your rights or legal literacy campaigns, human rights training for healthcare providers and police, stigma and discrimination reduction, and programs to reduce violence against women and harmful gender norms. Now, we measured these programs in Global Fund proposals, and what we found was that there's very low coverage of these programs if they exist. They're mostly pilot programs, they're very small projects. They mostly focus on stigma reduction with little done to address discrimination and criminalization. And what happens is that they're mentioned in the National Strategic Plan, but then as you go through to where they should be costed and then budgeted, they drop off. They're not costed, they're not budgeted, and they're probably not implemented. But people are not out there measuring the actual implementation. So countries are claiming to do a lot, and in fact think they might be doing a lot, but in reality it doesn't get done. Meanwhile, they're very good at laws. Now, we've got almost 30% of the countries reporting that they have no legal protection against HIV-related discrimination, and almost 70% saying that they actually have laws and regulations that present obstacles for vulnerable groups. And then we have at least 78 countries criminalizing same-sex sex, 6 with the death penalty, over 116, probably largely over, criminalizing some aspect of sex work, 46 countries still with HIV-related travel restrictions, 56 having an HIV-specific law criminalizing HIV transmission, and many more applying general criminal laws to this, and then most criminalize drug possession, and many criminalize harm reduction. So the criminal law is showing us the attitudes of basically of the parliaments and of societies. Now, what we're seeing is that in spite of great research projects like we've talked about here, we're getting much more pushback and very sophisticated pushback about this whole notion of discrimination, particularly applied to key populations. A number of those who disagree with the approach of saying that these people are suffering from stigma and discrimination and it's a bad thing, they're claiming that no, stigma is okay because it's expressing a society's disapproval of immoral behavior. The criminal law should uphold values, and when people transgress these values, they should be punished. Criminal laws regarding same-sex relations, sex work, and drug use are based on moral and religious norms, and they are reflecting the social views. Criminal laws are actually effective in reducing risky behavior and reducing sexual and drug networking. So they are effective in reducing transmission, and that there's no evidence that decriminalizing all these things is going to help reduce HIV infection. Now, these are the counterclaims that we're dealing with pretty much all the time, and they have, I must say, those who are saying these things have a lot of strong feelings about them, and they increasingly have a lot of money behind their views, money that is being used to influence policymakers, particularly parliamentarians, to ensure that the criminal law remains the way it is. Needless to say, in spite of all this, UNAIDS has made eliminating stigma and discrimination and eliminating travel restrictions, which we think are a proxy indicator of stigma and discrimination and a lot of other problems in a national response, as part of two of our main 10 goals. And these are reflected as well in the Political Declaration of 2011. So, what do we need? We've heard a lot about what we need, and I don't want to repeat that. Let me just say another thing to think about is the question of whether or not we heard at the very beginning the whole question about what is stigma versus what is discrimination. And you could ask different people about which is better to change first. Do you change attitudes and beliefs, or do you change actual behavior? Now, the law and human rights and anti-racism, has a long history of trying to change behavior that discriminates before it changes attitudes. And some would say that it's easier to change behavior. In other words, you can reduce racial discrimination by various laws against it, but you may still have a society full of racists. They just now know that they can't get away with their racism. So that's another thing to think of in what we need to do. But clearly we need to do a lot of things through a lot of different means. And I often feel like, if you have a soap opera that shows people living with HIV, or men who have sex with men, or a sex worker in a good light, and it's an entertaining soap opera, you've probably done more to change nasty attitudes and discriminatory behavior than all the changes in law in the world. Anyway, these are our programs that we say should be in every national response. But again, we don't see it happening. We don't see the money going to it. In fact, we're in a place when money is flatlined for the HIV response. And so where these programs existed, they're probably going to be the first to go. And I still have many funders say to me, I will not fund this program with HIV money unless you show me a direct relationship between, let's say, legal services. If people get legal services, does that mean that they're going to go and take up testing and treatment? Unless you can show me that, I won't fund them. So that's one I say to them things like, when we got rid of racial discrimination, did we have to show a health outcome? I mean, it is a good in and of itself to reduce stigma and discrimination. Clearly, any broad definition of health would include the removal of stigma and discrimination in someone's life, but even if you take it away from health completely, it is a good in and of itself. So I always say that when we talk about HIV, let's don't just talk about health, let's talk about health, dignity, and security. And our programs should have health outcomes, but they should also have dignity and security outcomes. Let's see here. So, we need to move away from stigma measurement. We have a lot of good stigma measurement, but we seldom have it followed up with real programs to reduce stigma. And I think these 7 key programs, if I go back to them, the purpose of them is, the simple purpose of them is to give resources to people in a society so that they can make the social and legal change necessary. But all of these programs are interconnected so that if you do a few of them at a time, you will start to get results that are beyond the simple nature of the program. Anyway, we need to get further evidence. In spite of the fact that I say that we shouldn't have to look for it, we need to get further evidence to show that reducing stigma and discrimination and punitive laws actually does lead to good health outcomes. Until we get that evidence, probably HIV money won't be used to fund these programs. We need to go beyond traditional health partners into the legal world. This is the parliaments, the judges, the religious community and traditional leaders, police, the national human rights institutions, and human and women's rights groups that are working on issues, sometimes just on HIV, but sometimes beyond HIV, and need to incorporate HIV. We really need to spend money making sure that people are mobilized for change. And what I'd like to say there is that as a human rights person, I'm very much I believe very much in mobilizing around rights. rights to me are a lot of things, but one of the things they are demand creation. Because until a person knows that they have rights, that they're entitled to something, then they won't make those demands for that very thing. So what I'd like to see is less sort of generic community mobilization or capacity building, and more community mobilization around local laws, rights, strategic ways of getting what you need and want. And then we need to work on the funding issues involved in this area, which are massive. Okay, thank you.
Thank you very much, Susan. Our final speaker is Ron McInnes. He's the Deputy Director for HIV at the Health Policy Project in the Futures Group.
Good afternoon. So my job here is to help stimulate the conversation, as if our speakers didn't do enough to do that. But when Cindy Grossman at NIMH agreed to, with her colleagues, support this satellite, we wanted to make sure that we had a conversation around scaling up. And I think some of the discussions that we heard today give us a lot to focus on, depending on what your area of interest is or what your particular discipline is. This is a scientific conference largely. We have great diversity and community participation, and I think you should keep in mind how often you're going to hear the term stigma this week. You'll hear it a lot. We've done surveys over the past years at international AIDS conferences and thousands of citations just in abstracts alone with the word stigma. Now, whether Susan's prescription is correct, that we don't need to measure it any further and we need to look elsewhere for funding, I don't know. But I think we've found ways to link stigma in our HIV treatment, care, and prevention programs. And I want to just walk through an example. We need to, as we think this through, what we want healthcare settings to be. And we know healthcare settings are very diverse around the world. Some of them are very impoverished settings, some of them are world-class institutes. But what is the ideal, and how do we aspire to that ideal? We shouldn't aspire to less. We know the realities, but let's keep pushing the envelope as we've always done in this movement for global health and for HIV. We want these places to be safe, we want them to be competent. There should be spaces where people living with and affected by HIV and their families can seek prevention, treatment, care, and support. To build the evidence, we need to keep building the evidence from across disciplines. Let's evaluate the anti-stigma interventions. Those that aren't showing results, let's stop them. Let's move on to different approaches. Let's determine whether the new trends in service delivery, whether it's through mobile technology or other areas, are having a more desired effect. Let's start measuring the impact of S&D on health outcomes, as been suggested. And we can do this in several areas, and I know there's a lot of work now starting up to do that. What can health systems aspire to do? There's a lot of discussion across global health of moving to more systems approaches. And these are the types of things that we want to see systems be able to provide for people around the world. Stigma-free facilities, stigma-free services, stigma-free. How do we get there? How do we get people to understand the true WHO definition of health? Body, mind, and spirit. It's all important, and if we don't invest more in these approaches, we're discounting the investments that we're making in HIV. The other connect here is the recent Global Commission report on HIV and the law, and if you haven't heard about it this week, I think you'll hear about it during the conference. Here, a pretty thorough review of laws and policies around the world and their impact on health and their impact particularly on the populations most affected by HIV. We need to expand our investments in this. Doing law and policy work and reforming laws or enacting them or removing old laws is a lot of work. It takes expertise, it takes resources, it takes strong participatory governance. And that is what's going to be needed to implement what the Global Commission has reported on. These global reports are great, but they only matter when countries themselves have the resources or make the resources available to actually act on what's been recommended by experts and studied and studied and studied. The other thing that Laura mentioned was the Stigma Action Network, and I just want to take 1 minute to talk to you a little bit about what this network is. It's a nascent group that started largely with researchers focused on HIV stigma and how to measure it, how to quantify it. Over the years, it's become a great partnership of community leaders from across organizations of people living with HIV, from people most affected by HIV, from groups of MSM, groups of persons who inject drugs, persons from gender organizations. And this partnership now has a wonderful website. Go to stigmaactionnetwork.org and look at the country-by-country data that we have on stigma. Look at the criminalized laws in each of the countries. Look at the evidence, the research, and the advocacy that's going on to reduce stigma. And the other component of this is around social capital, and Stigma Action Network also is a great repository to understand how community movements and professional movements need to merge together and build this approach. If we do, as Susan suggests, have a lot of naysayers, then what do we do to convince the naysayers that the approaches to stigma and discrimination, whether we call it something other than stigma, whether we call it what it is around, is it racism, is it misogyny, is it classism, is it whatever it is, what ism is it, and how then do we find solutions to break it down? And I think this network is a great place that merges all of these thoughts together. Please join, please contribute, and please be part of the discussion. And so now it's, I guess, time for our discussion. Thank you.
Thanks to all our speakers today, but we really would like to engage in a conversation. We have thought leaders, researchers, policymakers here, and we want to hear from you in terms of your thoughts on what was said. So we have mics in each of the lanes. I'll say lanes. So we'll start with, Fran.
Hi, I'm Fran Cornos from Columbia University. I found this a fascinating satellite. Thank you all very much. I just want to make a comment about discrimination that takes place at the International AIDS Conference, which is the discrimination against a focus on mental illness and substance use disorders as just as important as things like tuberculosis and hepatitis C. As someone who's a psychiatrist who's worked at the interface of HIV and mental health and mental illness since 1983, it is remarkably frustrating to see the discrepancy between all of the information we have available to us, how disabling mental illnesses are, how much special populations, key populations with high rates of substance use and other mental disorders, how much it affects access to care, receiving care, staying in care, all of its effect on the cascade, and yet mental health, substance use to a large extent, and mental health even more, is highly discriminated against in its presentation at this conference. Of course, it's discriminated against everywhere in the world. I remember once someone presenting a survey of who would you least like to live next to. There were 26 categories, and mentally ill were number 26. People would rather look at criminals or just about anything else. So we might also think about, in our own setting, the internal stigma against what we include and what we exclude, and it's very much along the lines, I think, of what Susan was talking about in terms of why perhaps we're not more effective than we can be. Not everything is about antiretrovirals.
Thank you. Thank you for your comment. And I'll actually just say I think it is important for us to get feedback, speaking now from the International AIDS Society. We have a members meeting, and that's actually important feedback for us to hear about. That's this Wednesday on the 25th at 12:30.
Yes, Doug Feldman, Department of Anthropology, State University of New York at Rockport, and also the president of the Society of Medical Anthropology. I just want to say that I think that a lot of people have been misusing the concept of anthropology, in anthropology, cultural relativism to justify their racism, their sexism, and so forth, and ignoring the much more important issue of human rights. I think human rights concerns trumps the justification for sort of cultural relativist viewpoint that some people tend to have. Having said that, I want to also say that people aren't just stigmatizing against AIDS, they're stigmatizing against the cultural attribute that's associated with it. They're stigmatizing against gay men, gay and bisexual men with AIDS, with transgender people with AIDS, injecting drug users with AIDS, with sex workers with AIDS. And that I think the critical issue and question that I have is that I think it's more important to just simply not just get to the level of tolerance. I think tolerating these groups is not really going to fundamentally get rid of the discrimination and stigmatization. I think what's needed is acceptance of these populations. And the question that I haven't heard the word acceptance here. Even this is an excellent panel, really good. I'm really glad I came here. But how do you get to a level in the general populations of acceptance to be able to produce the kind of stigma reduction that is necessary in HIV control?
I think that's an excellent point. I think we might even want to go one step further beyond acceptance to actually valuing the contribution. And I think our experience is that communities of sex workers, people living with HIV, and I think this is actually some ways in which programs actually don't do a very good job. They think that they want to sort of remove some barriers so there's a basic acceptance, without actually going the step further and saying, how can we think about the valuing of the contribution? And I think that a small vignette, one of the things that it was sort of one of those very small decisions that gets made when we were doing programs in rural India, and we had, everybody has sort of a resource bag with condoms and literature and those kinds of things. And it was a small decision. There were the sex workers who were working in the villages had a certain kind of bag, and the people who were working with other populations had another bag, and they were different colors. And the sex workers came back to us and said, look, we're not sex workers working in the villages on HIV prevention. We're people who are working on HIV prevention in the village, and we want to be valued for that contribution. And so they said, give us the same bags as everybody else has. And I think those are the kinds of things we have to continuously think beyond we're accepting this, to thinking about how can we make sure that this is actually, that their contribution is actually valued, not just in HIV prevention, but valued more broadly.
Well, thank you. Ron, did you want to?
Thank you for that question. I just wanted to say that, I think what's radical about human rights is that human rights values everyone at the exact same rate. So if we're all of the same value, we need to find ways to get society to believe that. Now, under the law, either civil rights or human rights protect minorities from being abused by majorities. And it's the starting point for basic, legal protections and being seen as equal. It's probably somewhere even below tolerance, but maybe it's tolerance when the majority is restrained by the law. It's certainly not acceptance yet, but I think that on the one hand you have law protecting minorities, on the other hand you have those minorities being empowered to no longer accept the devaluation that they have been experiencing, and to themselves value themselves on an equal par with others and be able to act that out and begin to interact with others in a way that shows that they are of equal value. And then through various processes, I think you get to acceptance. But you need to have these forces happening, I think, simultaneously in different ways. And what's sad is when the majority is able to discriminate against minorities, and the law not only does not protect, but the law is actually a part of that discrimination.
Thank you for that. Just so we can get to all the questions, can you just ask a question and we'll respond as quickly as possible? We'll go straight to the rear.
I'll be short. Leonard Christine with the Center for Public Health and Human Rights at Johns Hopkins. There were two words, it is a terrific panel, but there were two words that I didn't hear. Enforcement and accountability. We talked about laws, but I'm interested, Dr. Nyblade and everyone else, in this taxonomy of strategies. What about enforcement? And when I mean enforcement, I mean lawsuits, human rights mechanisms that bring consequences, various kinds of commissions. There's all kinds of accountability enforcement mechanisms. But I didn't hear anybody talk about that except to talk about the law generally. So I'd like to know where these ideas, enforcement, which has been so important in the United States, and around the world, it falls within this struggle.
I think that's an excellent point. I know in work that we're doing with USAID's Health Policy Project to support this particular need in countries, in Jamaica, in Ukraine, and in Ghana, community groups along with the AIDS commissions and human rights organizations are developing stigma and discrimination redress systems. So these are collective bodies now that will be interactive for people to anonymously or otherwise begin to report on various aspects of stigma and discrimination that they themselves will identify, and then they themselves will develop what they think redress should be for those, not only in collusion with what existing law is, but also in what facility level or other types of protocols that would be developed, say for instance the relationship that's nascent now between the police and many health clinics. So I think this is all in very experimental stages, at least the practical use around HIV, but it's nice to see it being spurred on.
So,
can I just respond and say, yeah, I think this is a very important point, and I think in looking, for example, in healthcare facilities where we're starting to develop facility-level policies, then that's an important piece of it then is what happens in terms of reporting and redress. And that is often the most difficult part of it to do, and I don't know that we've managed to get there yet, but that's an important part of it. I'd also just like to say, we're talking about a lot about laws and policies, but a lot of the discrimination that happens and that really hurts and has effects is not discrimination that's legally actionable, and I don't want us to miss that in this discussion. When you work in communities, it's what your family is doing to you, it's being excluded from social events. These are not things that are legally actionable, but they are incredibly difficult and important to address. And so thinking also about can you sanction something like that, or is that really around changing norms and demanding sort of rights in terms of participation?
in the rear, and we'll get to you next.
Association, and I have an invitation to an action that I'd like to invite you to. On Tuesday, the 24th at noon, there's a mobilization called We Can End AIDS. It's a march to the White House by 5 different branches, and one of the branches will address stigma and criminalization. It's the Harm Reduction Human Rights branch of this march, and we're meeting at 11:30 at 9th and K Streets, right in front of the convention center. We'll be joined by the other branches addressing other issues around HIV in Lafayette Park at 1 o'clock, and then we'll rally there and come back. So I urge everybody to come to this action. It's the least we can do while we're in Washington.
Thank you.
And it will build the human rights campaign.
Thank you. Yes.
Yes. I have 2 questions. First, to Mr. James, that you have said that in India, most of the sex workers are low caste. So do you have any study it proves that, sex workers are in low caste? And second thing, that we are from half an hour, we are just talking about stigma and zero we have to bring down the stigma and zero, but no other sex workers are here. Why? Thanks.
It's a good question. The answer is yes. I think it differs in different parts of India. In a lot of the rural areas that we've worked, the sex workers are almost exclusively low caste. In other areas, they're not. So, for example, if you look in northern Karnataka, southern Maharashtra, most of the sex workers, particularly those engaged in the Devadasi tradition, they tend to be very low caste, and so they have the double issue. But in urban areas like Bangalore, we find that it cuts across caste. It's not such an issue. So my point wasn't that all sex workers, and I hope I didn't leave the impression that all sex workers are low caste, but I think that where there's both issues, I think that both issues become a constraint. So I don't know if that answers your question.
I'm not happy with your answer, and I would like to mention one thing. In Karnataka and Maharashtra, we have the Devdasi system. It does not belong to caste. It is a system for the woman to get married with a god, so she can be a sex worker.
No, I recognize that.
Yes, please.
I recognize that.
And second, why are the not sex workers have called me here? Because it should be a larger platform for them to raise the issue. And when we are talking about 0, 0, 0, so what is 0? Thanks.
I'm sorry, I think it's really important to mention that there are very few sex workers who have been able to access this conference because they have been systematically excluded by the visa program from getting into the United States, as well as people who use drugs. So two of the really important pillars of our movements are absent, and I hope that everyone is paying attention to what sorts of strategies we can do in the future to make sure that this never happens again. I think it's a tragedy, and I honestly think it's a shame.
Yeah, I think we are in agreement with that. The conference organizers have developed what they've called hubs for various segments in order to engage with the conference, but it is unfortunate that we do not have what we think is a significant presentation by sex workers at the conference based on policies. We'll start here and then end with your question in the back.
My name is Edward Sanders. I'm based in the Kilifi, Kenya Medical Research Institute, Kilifi, Kenya. Thank you very much for the presentation, Susan. I come from the outer world into the inner world. I'm now in the AIDS inner world. I'd like to share something from the real world that I've been working with for the past 7 years with medical sex workers, female sex workers. If you would ask me now, please apply to a fund to do stigma reduction to a particular fund next year that's focused on stigma, or we want to train health workers on STI management for MSM who have health workers have no knowledge about anal sex. I would go for the one that have just been funded by USA. We have had a successful training, an MSM sensitization training, and we then measured the reduction in stigma pre and post training. And I think it goes hand in hand, so I would want to argue for a separation of stigma reduction. Health workers have very little knowledge, and you see the stigma, the prejudice going down the moment you give them knowledge. If you would like to comment, please.
No, I think I agree with you completely.
large, impoverished, and I'm wondering if you can point me in the direction of a toolkit or practical tools that are not for research but would be for a clinical setting to assess stigma in our clinic and address stigma in our clinic. So something very practical that a busy clinician could use.
I think that's a question for me. Yes, there are some tools, and I think they maybe would need to be tailored a bit, but everything is available on the Stigma Action Network. But there are tools, for example, that focus specifically on reducing stigma towards drug users. And there are also tools that focus specifically on how to work with training health providers around these issues across all the groups that are experiencing stigma. And I think someone else said earlier around sort of that intersection of stigmas that I imagine your clients are experiencing. I'd be happy to talk with you more afterwards.
Thank you thanks for that question. Actually, I was going to bring up the Stigma Action Network because there are really wonderful tools on the website. We'll take one. Yes, go ahead.
Okay. Thank you so much. It was a very interesting session. My name is Sarita Jadhav and I work in the UNAIDS India office. I have two questions, one for Laura and one for James.
We can only do one.
Okay.
I just want to get to
James, you mentioned about the training of police personnel in Karnataka. Now, we at UNAIDS also work very closely with the Ministry of Home Affairs and are trying to, advocate for a more enabling environment where organizations can implement better interventions with key populations. I'd like to know, have you done any study about the cost effectiveness of these trainings? Because in a country like India, we have over 2.5 million police personnel alone. Some central police and some state police. So we find that instead of doing one-day training sessions and sensitization workshops, we should try and integrate human rights issues, HIV and all this in the police training curriculum. We have police training institutions and academies all over the country.
Thank you.
And that we have found as a very useful work.
It's a complex question. I actually am not in favor of looking at picking apart comprehensive programs for sex workers and looking at the cost effectiveness of each component. I firmly believe, for example, that you have to think about a program holistically. And I think if dealing with issues of harassment, police violence are seen as an important part, then you have to evaluate that as part and parcel of the entire program, rather than saying, is this cost effective, is that cost effective? I think a program for sex workers has to include issues of rights, issues of violence, issues of stigma, issues of discrimination. So I would put it into the whole bundle, because this idea of sort of picking apart, well, this part contributes this much, this part contributes that much, I think it's a false way of thinking about things. And so I would say that overall, sex worker programs are cost effective, and a good sex worker program includes a focus on stigma and discrimination, including looking at the disempowering context.
Thank you for that short last question.
My name is Alona, I'm from Israel. Susan, you're my new hero. Thank you very much. I'm a person living with HIV. I just attended Living 2012. The major issue, I think one of the major issues we talked about was discrimination and stigma. Two things. One, people living with HIV around the world need to be more mobilized. They need to know their rights and need to know the laws in their countries. Second of all, this is where you guys can help us, is we need somebody to enforce these laws with our governments. My NGO is the only thing in Israel working for advocacy and discrimination and anti-stigma. The government takes care of prevention, but that's about it. We have no way of enforcing our government to help us with this. So I'm calling on you guys to help us with that. Thank you.
Thank you very much for that comment. It's very important. It's been an honor to be part of this panel. Before we close, I just want to thank Cindy Grossman, because this panel would not have been possible without all of her hard work. And thank you all very much.